All right, let's discuss antifungal medications. For this part, I would like you to get a piece of paper, I don't know, a whiteboard, something you can write on or something you can draw on. And I'd like you to make this sketch along with me. And I want you to follow along this storyline. Try to think of antifungal agents the way I'm going to describe them. Try to be able to give the same description, and it will be extremely easy for you to remember all the medications and their mechanism of action. For this section, the mechanism of action is like the most important part. And then for some medications, you have to know what exactly they're used to treat. It's pretty simple. We'll talk about it. And the side effects, of course, right? The mechanism of action and side effects are the biggest parts for most of the medications at step 1 level. So when you think of antifungal medication, consider a fungal cell, a fungi, or a fungus, a fungus. So, of course, they have a cell membrane. All I needed to know is remember the parts, and I needed to draw as well. So draw your own cell membrane. A fungus would have a cell membrane. They would also have, or it would also have, a cell wall around or outside of this cell membrane. You want to remember that the cell wall of fungal cells is made of beta D glucan. The cell wall of the fungal cell is made of beta D glucan, and the cell membrane is made of a glycerol. The cell membrane is made of a glycerol. Like every other cell, or most other cells at least, inside of the cell we are going to have structural features. We have things that help the cell maintain its structure and that help the cell carry out some basic properties. What are we talking about here? Microtubules. So fungal cells have microtubules. Microtubules help maintain the structure. They play a role in transport of substances within the cell. Literally every cell has its own form of microtubules. So fungal cells also have microtubules. What else do fungal cells have? They have a nucleus. Every cell sort of has a nucleus, and within this nucleus they have DNA. Within this nucleus they have DNA. So fungal cells are not different. They have a cell wall, they have a cell membrane, they have microtubules inside of them, and they have DNA as well inside of them. So when people began thinking of how to treat fungal diseases, somebody has candida, somebody has, I don't know, histoplasmosis, or any of these your fungal abnormalities, people began thinking, doctors, scientists, how can we treat these diseases? And someone figured out, well, what if we can destroy the cell wall of the fungal cell? Right? You have a fungal infection. How can we get rid of it? Let's destroy its cell wall. And that's how they came up with one medication, a class of medication that inhibits the cell wall of the fungus. And those will be your echinochandins. Echinocandins. The classic medication is going to be Caspofungin. You also have micafungin and all of that. But someone looked at the cell wall and said, okay, if we can destroy the cell wall, we'll be hurting the fungal cell. So let's make something that can destroy the cell wall. And they made echinocandins. So if I asked you what's the mechanism of action of caspofungin, of echinocandins, you should be able to tell me that they inhibit fungal cell wall. They inhibit beta D glucan on the fungal cell wall. I hope that makes sense. Okay, someone else looked at the cell membrane of the fungus and thought to himself, okay, what if we can destroy the cell membrane? If you remember something from general pathology, when you destroy the membrane of the cell, that is one of the hallmarks or the hallmark of irreversible injury. The cell will die. When you destroy the cell membrane, the cell will die. So someone said, okay, how about we make a medication that would destroy the cell membrane of the fungus or fungi? And they came up with a number of medications. First, they made a medication that would make pus What if we can poke holes on the cell membrane? And amphotericin B was born. Amphotericin B and nystatin. Amphotericin B and nystatin. Amphotericin B and nystatin make pores on the cell membrane. Amphotericin B and nystatin make pores. They make pores. They poke holes on the cell membrane, basically destroying the cell membrane. And someone else thought, okay, what if we can stop the fungal cell from making a cell membrane in the first place? We can do this by inhibiting the steps involved in egesterol synthesis, and we can briefly look at the steps involved in egesterol synthesis. Egesterol is made from a substance we would call squalene. Okay, squalene is converted to squalene epoxide. Squalene epoxide in a series of steps is converted to lanosterol, and lanosterol is converted to egesterol. Egesterol is in fungi just like cholesterol is in humans. And the enzyme that converts squalene to squalene epoxide is squalene epoxidase. Squalene epoxidase. The enzyme that converts lanosterol to egesterol is 14 alpha demethylase. So someone thought, what if there was a way to actually inhibit the synthesis of egesterol? How can we do that? We can do that by making a medication that will inhibit the enzymes that help egesterol synthesis. So let's make a medication, for example, that would inhibit squalene epoxidase, and that medication was terbinafine. So if I asked you what the mechanism of action of terbinafine is, you would say, okay, terbinafine inhibits squalene epoxidase. Terbinafine inhibits squalene epoxidase. And then they made another medication that would inhibit the conversion of lanosterol to egesterol. And that medication was your Azole drugs. Drugs like Ketoconazole or itraconazole, ketoconazole, and so on. Those are the Azole medications. They end in Azole. That's why we call them Azole drugs. Those medications inhibit 14 alpha demethylase. So far we've seen about 4 or 5 medications. We can destroy the fungi by destroying its cell wall. The cell wall contains what? Beta-D-glucan. And what was the medication that inhibited the cell wall? Echinochandins. Classic medication, Caspofungin. Echinocandin is the class name. Caspofungin is the specific name. Then we decided, okay, what if we can destroy the cell membrane? There are 2 ways. We can make pores on the cell membrane, just straight up bulldoze the cell membrane, poke holes in the cell membrane. Amphotericin B, nystatin. So what is the mechanism of action of amphotericin B? Amphotericin B makes pores in the cell membrane of fungal cells. It's like the most potent antifungal agent we have. The other way is to inhibit egesterol synthesis, stop the fungal cells from making their cell membrane in the first place. And we did that by giving or coming up with terbinafine that inhibited squalene epoxidase and Azole medications that inhibit 14 alpha demethylase. So medications like itraconazole and ketoconazole. You want to remember that. Of course, there are other ways we can attack this fungal cell. We can make a medication that will inhibit the microtubules. What if we make a medication that will inhibit the microtubules so that this fungal cell cannot transport substances within itself? If it cannot transport substances, it can hardly survive, right? And the medication is Griseofulvin. the medication is Griseofulvin. So what's the mechanism of action of Griseofulvin? You need to be able to tell me that Griseofulvin is a microtubule inhibitor. Griseofulvin is a microtubule inhibitor. And finally, we made a medication that would inhibit the DNA of fungal cells. Medication that would inhibit the DNA of the fungal cells. And that medication was flucytosine. If you remember all these medications, voila, you know all your antifungal medications. It's that simple. You're either destroying the cell wall with Echinochandins, Caspofungin, or you're destroying the cell membrane by making pores with Amphotericin B, Nystatin, or you're preventing cell membrane synthesis, egesterol synthesis with Azole medications, Ketoconazole, itraconazole, miconazole, clotrimazole, or you're inhibiting the DNA with flucytosine or inhibiting the microtubule with Griseofulvin. I hope you drew this diagram and I hope you've labeled the diagram as well. I want you to try to reproduce this diagram on a separate piece of paper without looking at what we've already done and see how well you can recall that. Let's start by looking at some of these medications. We looked at the cell wall first. So we said one of the ways you can destroy fungal cells is by destroying their cell wall. If you're going to destroy their cell wall, you need to give the medications we called or referred to as echinochandins. Echinochandins, the model medication, the one you're going to see all the time, is Caspofungin. But remember, there is micafungin, I think there is anidulafungin or anidalufungin, something of that nature. But at least you should remember one of the members of that class. Caspofungin is like the classic agent. So what is the mechanism of action of caspofungin? You should be able to tell me that they inhibit beta-D glucan on fungal cell wall. Or you should be able to simply say that they inhibit fungal cell wall synthesis. They inhibit the fungal cell wall synthesis, or they inhibit beta-D glucan synthesis on the fungal cell wall. Anyhow you think of it, just remember that echinocandins inhibit beta-D glucan. You use them for a number of fungal infections, including candida, aspergillosis, and all of that, but the use is not important. You should be able to give me their side effect. That is important. These medications will cause flushing and GI distress. For this particular medication, their mechanism of action is the only important thing. Your exam does not care so much about their side effect. The mechanism of action is crucial. You have to know it. I'll give you an example of a type of question you could see on your exam. They would give you a scenario where a patient, say a 48-year-old man, was treated for a fungal infection with caspofungin with no improvement. Maybe he's been treated for a week, but he did not make any improvement. And then he was given Amphotericin B. On adding Amphotericin B, this patient had rapid recovery or rapid improvement. He made rapid improvement. Why? On adding Amphotericin B, the patient made rapid improvement. He's been treated with caspofungin for a week and he did not improve, or he did not make significant improvement. And then when they added Amphotericin B, he improved rapidly. Why? What would you pick as an answer? What would you think is the reasoning behind it? There are a lot of options. The most or the best answer to this type of question is going to be this. The caspofungin destroyed the cell wall of the fungi. So it was easier for Amphotericin B to get to the cell membrane, making Amphotericin B more efficacious. Right? So because you've been treating the patient with caspofungin for a week, caspofungin has destroyed the cell wall of the fungi, right? But remember, destroying the cell wall does not kill the organism. It is destroying the cell membrane that is the best way to kill any organism, literally any living organism. So because caspofungin destroyed the cell wall of the fungi for this 1 week period, amphotericin B had easy access to the cell membrane, and that was why this patient improved rapidly. That's actually a question I think that has been asked somewhere before. So you want to remember that once again, caspofungin inhibits synthesis of fungal cell wall, inhibits beta D glucan on the fungal cell wall. The other medications we saw were medications that were inhibiting the cell membrane. We went to the cell membrane and we talked about amphotericin B. Amphotericin B. Amphotericin B is like the most potent antifungal agent that we have. It's the most potent antifungal agent that we have. And if I asked you, what is the mechanism of action of amphotericin B? I hope you immediately said it makes pores on the fungal cell membrane. It makes pores. It makes holes on the fungal cell membrane. Take note, it's not on the cell wall, it's on the cell membrane. And if you poke holes in the cell membrane, everything inside of the cell leaks out into the environment, right? And basically the cell is, imagine somebody punctures makes a lot of holes on your body. That's it, GG, right? You're done. Good. So that's what amphotericin B is basically doing to the fungal cell. It makes pores on the fungal cell membrane. You use amphotericin B usually only when you have severe fungal infections. This medication is extremely toxic, so you don't want to use it just for fun. You use it when it is absolutely necessary, usually for serious systemic fungal infections. Serious systemic fungal infections. What is the side effect of amphotericin B? What are the side effects? The first thing you want to remember is electrolyte abnormality. Electrolyte abnormality. And specifically, you want to remember that amphotericin B causes hypokalemia and hypomagnesemia. Amphotericin B causes hypokalemia and hypomagnesemia. You should remember that. Why? Because it damages the renal tubules. It damages the renal tubules, causing hypokalemia and hypomagnesemia. Does this make you think of any other medication from any other place? Are you thinking of foscarnet? Are you thinking of foscarnet? Look up foscarnet and look at the electrolyte abnormalities that are caused by foscarnet. Amphotericin B causes hypokalemia and hypomagnesemia. The other side effects of amphotericin B will be shakes and bakes. That's what it's called. Basically, fever and chills, right? Fever and chills we describe as shakes and bakes. There are a lot of things that could happen in people taking amphotericin B. Anemia would be one of them. You need to give these patients a lot of fluid to try to mitigate the toxicity of amphotericin B, okay? They cause anemia, they cause nephrotoxicity, etc. If there's anything I'm very interested in when it comes to amphotericin B, I need you to remember that it causes hypomagnesemia, hypokalemia, renal abnormality, fever and chills, whatever. Remember the mechanism of action. Amphotericin B makes pores on the fungal cell membrane. That would be important to use it for serious conditions. The other medication that works just like amphotericin B is nystatin. Nystatin. Nystatin also makes pores on the cell membrane, of course, of fungal cells. It makes pores. If you remember, we saw nystatin all the way here. Nystatin makes pores on the cell membrane of fungal cells. What do we use nystatin for? Here you actually need to know the uses, the two big uses on your exam. Swish and swallow for oral and esophageal candidiasis. So we call swish and swallow. You put it in your mouth, you go, whatever, right? Oral and esophageal candidiasis. And you use topical Nystatin for candida vaginitis. This is actually pretty classic. These ones are common, like they come up on the exam. So that's why I'm giving you those examples. Oral and esophageal candidiasis, candida vaginitis, Nystatin plays a role or is used in those scenarios. Then we saw medications that inhibited egesterol synthesis. I hope you're thinking of your Azole medication, Azole drugs. What is the mechanism of action of Azole drugs? You should be able to tell me that these medication inhibit egesterol synthesis. This is the big picture way of saying it. If you want to be more specific, which they can do on your exam, you should be able to say that they inhibit 14 alpha dimethylase. And you want to also remember that 14 alpha dimethylase is a P450 enzyme. So by default, your Azole medications are P450 enzyme inhibitors. P450 inhibitors. They inhibit 14 alpha dimethylase, which is a P450 enzyme. You want to remember that. There are several Azole medications. You don't need to memorize all of them. I don't think I know all of them myself. But we have ketoconazole, itraconazole, voriconazole. Then we have azole medications that are, I think we have isovuconazole as well. Then we have azole drugs that are topical. We have topical azole drugs, two of them, miconazole and clotrimazole. Miconazole and clotrimazole are topical azole drugs. Other azole drugs will be ketoconazole, itraconazole, voriconazole, isovuconazole, and so on and so forth. Miconazole and clotrimazole are topical azole drugs. What are the side effects of these medications? They don't have major side effects that you want to be worried about. But ketoconazole causes gynecomastia. Ketoconazole causes gynecomastia. You want to remember that ketoconazole inhibits one of the enzymes in your testosterone synthesis pathway. So it inhibits testosterone synthesis technically. And because you're reducing testosterone in a male, you're going to cause gynecomastia. That is what you want to remember. There, those are azole drugs. The other medication that inhibited sort of egesterol synthesis, but more specifically lanosterol synthesis, was the medication terbinafine. Terbinafine. Again, I'm not stressing the uses of these medications. You just think of any fungal infection that comes to mind. You can use them for it, right? As long as it's not the worst case scenario. If it's the worst case scenario, you want to use Amphotericin B. But general fungal infections like histoplasmosis, coccidioides, and whatever, you can use any of these antifungal agents. Now, when it comes to terbinafine, we already said that terbinafine inhibits squalene epoxidase, the enzyme that converts squalene to squalene epoxide, right? The enzyme that converted squalene to squalene epoxide, squalene epoxidase. And what you want to know is that we use terbinafine more for skin infections. Skin infections, what we call dermatophytes. Dermatophytosis, I think. We use terbinafine especially for skin infections, skin, onychomycosis, nails. So if someone has just basically skin and nail infections, you can think of terbinafine here. So we are not going to be using terbinafine for like coccidioides or whatever the case is. It has a couple side effects. I think it causes headaches, hepatotoxicity, dysgeusia, abnormal taste. Okay, you want to remember that for terbinafine. Again, I'm not so interested in their side effects here. Terbinafine inhibit squalene epoxidase. That's the most important thing. For your antifungal agents, their mechanism of action is the most important part for you. Take note of that. So we saw terbinafine and azole drugs inhibiting the cell membrane, and then we went inside the cell and we saw griseofulvin inhibiting microtubules. Griseofulvin, we said if you want to destroy fungal cells, you can also inhibit their microtubules, and you can do that with this medication, griseofulvin. When you think about griseofulvin as a microtubule inhibitor, are you thinking of other medications that are microtubule inhibitors? Which other medications do you remember that are microtubule inhibitors? Do you remember any antifungal drug? Antifungal. Do you remember any anti-cancer medications? Any anti-cancer medications that inhibit microtubule? I hope you're thinking of paclitaxel. You're thinking of vincristine. You're thinking of vinblastine. Do you remember any other medication somewhere else that inhibit microtubule? Are you thinking of colchicine? And of course, we are now talking about griseofulvin. I think there's a medication I'm leaving out. Don't I don't quite remember it. But at least you should have sort of an idea of what general class of medications that do certain similar things might be. Paclitaxel, vincristine, vinblastine, colchicine, griseofulvin. Those are examples of microtubule inhibitors. And I hope you remember the toxicity of these medications, especially those anti-cancer drugs, vincristine and peripheral neuropathy, vinblastine and bone marrow suppression. I hope you're thinking of all of those things. All right, then we talk about griseofulvin. Griseofulvin, mechanism of action. This medication inhibits microtubules. Of course, fungal microtubule. You want to remember that. Remember that microtubules play a role in cell division. So by inhibiting microtubule, you inhibit cell division in this tissue. When people take griseofulvin loves keratin-containing tissues. So your nails, for example, griseofulvin will love the nails. It accumulates in keratin-containing tissues. As the nails. Now, if it's accumulating in keratin-containing tissues, it only makes sense that you're going to be using griseofulvin for more fungal infection related to the nails, right? Like, again, onychomycosis. You can also use it for skin infections like what do we call it? Dermatophytes, ringworm, tinea, the different types of tinea. You can use it for all of those type of things. Skin, nails, just like terbinafine. You remember that. So griseofulvin, again, the most important part is microtubule inhibition. Their mechanism of action is the most important. The side effect, griseofulvin is going to cause, what do we call it? Disulfiram-like reaction is probably the big one. Disulfiram-like reaction is probably the most popular side effect of griseofulvin. Griseofulvin is an inducer of P450, is teratogenic. So pregnant women are probably not going to be taking this medication. If this medication induces P450, the implication is that if you take it with certain other medications, it's going to decrease the efficacy of those medications. Say, for example, warfarin. So if a patient is taking warfarin and then you give them griseofulvin, what's going to happen? Griseofulvin is going to upregulate P450, induce P450, increase the rate of metabolism of warfarin. So now warfarin is not going to be working as efficiently. And warfarin is supposed to prevent thrombus formation, say in people with atrial fibrillation, for example. So I give you a patient with atrial fibrillation that is taking warfarin. His INR has been normal for a while. Well, it has been around 2 to 3, right, as it's supposed to be. Now he started on a medication, and all of a sudden his INR is less than what is supposed to be, is lower, so it's 1 or something of that nature, and he has a stroke, for example. What are you thinking about? Okay, maybe the medication that he was now given was a P450 inducer, decrease the efficacy of warfarin. Because the efficacy of warfarin is decreased in a patient with atrial fibrillation, he managed to make a thrombus, and now that thrombus has gone to the brain and caused a stroke. This is what happens when you give P450 inducers to patients that are taking, say, a medication like warfarin. P450 inducers would decrease the efficacy of those medications. In this case, warfarin, P450 inducers would decrease the efficacy of warfarin. You want to remember that. Finally, we saw flucytosine. Flucytosine. Just remember that flucytosine inhibits DNA. Okay, DNA polymerase, I think. I think it also inhibits RNA polymerase. You can confirm that, but I think that is the case. So they inhibit DNA polymerase and RNA polymerase. These medications are like derivatives of 5-fluorouracil. They're very similar in that sense. Flucytosine is very similar in that sense. There's only one place where flucytosine is used, and it is in cryptococcal meningitis. You remember the type of patients that get cryptococcal meningitis. You would remember HIV patients, immunocompromised patients. Usually when you give flucytosine, you'd give flucytosine in addition to amphotericin B for cryptococcal meningitis. But amphotericin B can be given alone. So it makes you wonder, okay, so what's the use of flucytosine really if we can give amphotericin B by itself? But it's going to improve the efficacy and the outcome, I guess, when that treatment combination is used. So flucytosine, cryptococcal meningitis, together with amphotericin B, right? Flucytosine plus amphotericin B for cryptococcal meningitis. Side effect, if it's a medication that's inhibiting DNA synthesis, it's going to cause bone marrow suppression. If you remember all of these, you know antifungal drugs. Once again, go back to the beginning. We inhibited the cell wall with Echinochandins, Caspofungin. We inhibited the cell membrane. We made pause with Azole drugs. We made pause with Amphotericin B and Nystatin. We inhibited the fungal cell membrane synthesis with Azole drugs, with terbinafine, which was inhibiting squalene epoxidase. And then we inhibited the microtubules with Griseofulvin. We inhibited the DNA with flucytosine. It's not a lot of drugs, and I think now you should be able to remember your antifungal drugs. Try to reproduce this diagram without looking at this, and then compare it to what you have, and I think you'll develop mastery of it easily.